Okay, welcome back, everyone. For those of you I have not had a chance to meet yet, I'm Ritu Agarwal. I'm one of the co-organizers of this conference, and I'm also the co-director of the Center for Health Information and Decision Systems with my colleague Gordon Gao, who you just met. It is my pleasure today to introduce our industry keynote. Dr. Glenn Tobin is the Chief Executive Officer of Crimson, which is an advisory board company. In this role, he leads the Crimson organization on its mission to be the national leader in supporting hospitals and health systems, in driving cost, care, quality outcomes, improvements through physician-focused analytics, technology, and services. So he works exactly in the space in which this conference is all about. Prior to joining Crimson, he's held a number of very important positions across many different organizations, in fact, the entire healthcare ecosystem. He was the Chief Operating Officer of Cerner Corporation, who we all know and love as one of the biggest electronic health record providers. He was also the Chief Operating Officer of CodeWrite, which is a computer-assisted coding company. And early in his career, he was with McKinsey in a consulting role as part of their global healthcare practice. Dr. Tobin has a degree from Harvard University, a PhD. Yes. So please join me in welcoming Dr. Tobin. Looking forward to his remarks.
Thank you very much for the kind introduction. It's great to be here. When I was thinking on the way over here, I was remembering back to when I was doing my PhD, and I thought about a couple things I learned there. I think probably the most important as a PhD student was to leverage available and existing technology. And for me, that meant I think I was probably the first person in my program to actually use word processing software to generate my dissertation. And I am 100% certain I would not have finished had I been left alone with a typewriter to actually to crank that whole thing out. And the other thing I learned, I think, is probably maybe a little bit more relevant to this audience today, is that it's really difficult to find a great question on a worthy topic, and it's even more difficult to then have a unique source of data to try to figure out the answers to it. I think, in my career, I think I feel really lucky to have had a chance to actually work on, for the majority of my professional life, kind of what I consider to be a very, very worthy question, which is, how do you actually drive change in healthcare using IT in a way that is possible to use it? I think this conference is addressing, kind of exactly what I've spent my entire life trying to actually accomplish. And I hope that as you're, kind of listening today, rather than thinking about me as someone who just takes a really, really long time to get anything done, I hope you'll think about it as this is a worthy problem in all of its dimensions, meaning it's really hard, it's really tangled to try to sort out. And the good news is I think we're at the very beginning of what can be, a really fantastic next 5 to 10 years. So the other thing I realized when I was coming over this morning is that I had butterflies in my stomach, and I usually don't actually get very nervous anymore when I speak in front of a group of people. And I think it's because I transported myself in the car as I was coming over to some of the seminars that I did as a graduate student with a group of faculty members talking about my impending research. And I think the first few of those conversations didn't go very well, so I was imagining that hopefully this won't be something that was that will be similar to that. So let me just give a little bit of my background and kind of going a little bit beyond what Ritu had to say. So I started working on this question in 1994. And trying to use information to try to drive healthcare. At the time, I was actually very optimistic that we were on the verge of a massive breakthrough in how things would happen. I got involved in the EMR industry at Cerner before there was an EMR industry, and it was a very small place. And we were just trying to figure out how this whole thing could play out. And again, I believe that there was very beneficial change was just around the corner as well. When I got to the NLP company that was focused on coding, and what was really a focus on understanding the free text aspect of what's in the medical records, I was a little bit more seasoned, and I had a strong belief that the structured data that is kind of the dominant paradigm and methodology associated with EMRs was actually part of the problem. And so trying to figure out how do you actually use the text and the narration, which is so important in healthcare in terms of trying to understand what's really going on, how do you use that in a productive way? And again, I feel like I still may be a little bit crazy, but 20 years later, in my current role at Crimson, I actually am now certain that change is just around the corner and that we're going to be able to start using information in a much more intelligent way in the very near future. And my wish, I think, for all of you is, as you're delving into this worthy topic, that you all find angles on this to actually drive meaningful change that will probably take a very long period of time. So let me tell you just a little bit about Crimson. I'm just going to go here just to show you kind of just in terms of what we do to provide some background and context for the rest of my presentation. So what we try to do is we're actually trying to use data that's available to actually create insight to drive meaningful change in certain aspects of the healthcare delivery system. So we don't do much on the payer side, we do very little on the pharmaceutical side, but really trying to think about how do you help the providers of healthcare actually do something different. We're not an EMR company, but we are, thankfully, there is electronic information now, whereas there wasn't 20 years ago. So we try to access every piece of information that we can, but not just from EMRs, but also from other data sources, as one of the speakers mentioned before, consumer data, marketplace data, all kinds of things to try to figure out how to solve certain types of problems. And we're working, the interesting thing here is that we're working literally with thousands of organizations trying to create lightweight analytic applications that they can use to go drive change. And again, it's all in the focus of driving costs down, quality up, access to be better, the satisfaction of the human beings, who we used to call patients, but the satisfaction of the human beings to drive that way up. And because we see a lot, we're pretty confident that we're working on three pretty important problems, if you just think about it. And just very, very quickly, how do you actually grow in an appropriate fashion in this new world? The second one is how do you actually change the practice of physicians so that we literally reduce the variation in care in a way that we've been talking about now for 15 to 20 years. But what's the mechanism used to take data and enable physicians to improve themselves working with their institutions? And then third is how do you think about assuming total cost and quality? How do you assume taking risk on the provider world, and kind of shifting some of that risk from the payer universe, which has not been very well managed historically in terms of an effective outcome to improve cost quality. But how do you actually do that from within the provider universe? And everything we're doing is really in light of kind of all the industry changes that are going on in healthcare. But just in case I go on too long on any one page, I want to make sure I got my overall kind of point of view. Because some of the overall points of view that I think are the most interesting to us, at least, out there. And I think if you look at the last 15 years in healthcare, the interesting thing is healthcare IT, there's been a dominant strategy, which has been implement EHRs. And we're actually a long way through that. And I think we can all point at ways that hasn't worked. It's not quite done yet. But from a strategic perspective, the question has been answered regarding will healthcare organizations be using electronic information on a going forward basis? And we're at really in the moment we're at right now is very different than it was 3 years ago, where we were still in the middle of this, just like, how do we get these things in? And now we're actually kind of in a different era, which is how do we get value out of them? And that's the terrible problem that we're trying to struggle with today as an industry. It's just really hard to figure out how the EHRs are creating value for organizations. And so as we think about this, kind of this post-EH era, the core that we're trying to, that we think is important and that, I think hopefully will resonate with you all in the room is how do you actually kind of drive behavior change at scale? And it's the at scale part that the IT now allows us to do. Whereas before you could do kind of small pilots, you could do a variety of things kind of locally. Now the opportunity is to do things at scale. And we are far, far from being able to do it. But again, I think the next 5 years offers really tremendously unique opportunities to do so. And the magnitude of change that we can now drive because of where we are, I think is really kind of extraordinary. All this is in light of what's happening in the industry, and you all know this as well as I do. I'll just run through this very, very quickly, but margin management, which really means prices are too high, the trend line is going up too fast, and nobody is going to pay at this rate going forward. CMS has established very clear pathways forward that they are reducing reimbursement for hospitals in some of the latest legislation and regulations that they've put out. Private sector employers are trying to do the same thing. It's just unsustainable. And from a provider perspective, this turns into a question of margin management. How do I avoid going out of business? Then going up, the population health management is really the dominant theory of the case, shifting risk onto providers. They'll be able to manage the cost better than the previous paradigm, and we'll be able to really kind of start to drive some change. Still an unproven hypothesis overall, but there's some interesting possibilities there. That's then combined with number one, which is the creation of the retail market, which is being driven both by the public and private exchanges, but also by employers who are systematically and consistently driving up the amount of risk that individuals pay. And so the amount of the amount of transparency or interest that people have in terms of the economics associated with their health care is going way up, and I think you can see that in a ton of different data at this stage as well. And then finally, kind of on the, kind of a little bit exogenous to all of this, but we are all changing our view of how we deal with large, paternalistic, opaque, unfriendly organizations. We are just not okay with it anymore. I mean, most people are. And this is also driving a fundamental relook in terms of how healthcare executives, the hospitals and physician side, think about how they have to position themselves. And the retail revolution that's being brought about by CVS or by Walmart and by other types of organizations is very, very profound in the healthcare system today. And folks who are thoughtful are very scared that the profitable parts of their business is being consistently chopped off. So none of this is anything about IT, of course, but it does, I think, set this context for why there's something meaningful that can happen today. And it's really about pressure being brought to bear on the system in a different way, particularly as long as the changes in payment reform keep going, I think IT actually becomes a much more interesting part of the future of how this whole thing works. It's still just beyond our grasp. I kind of created this red line on the vertical is value from technology change, on the horizontal is time. When I first started getting involved in this, IT cost in healthcare providers was something related to, kind of in terms of the magnitude of spending, is we were just below the metals and mining industry in terms of how much money on IT healthcare spent. So it was really just a cost to be minimized, and it was primarily based around revenue maximization and revenue management in the early days. Enter EMRs, kind of leading up to this second dot on the page, and there was a big hope that if you take the paper out of healthcare, everything will start to get better. Turns out it was necessary, not sufficient in terms of making real change. And any organization that you follow today, what you see is that this kind of promise of IT-driven ROI is still very, very elusive. It's interesting, though, to when you link the rollout of the EHRs to the economic side of things, the public funding of the EHR rollout has been absolutely crucial. We started working on that in the year 2000, I think, in terms of trying to build the policy foundation for public funding of our industry. I went to work. I went and kind of organized some stuff with the RAND Corporation in 2000, 2001 to try to get an assessment of how do you think about kind of externalities, basically public goods argument more or less. And we funded a small research study. They kind of did some, kind of proved the feasibility that this could be determined. That then led to a much broader collaborative of a series of organizations that funded the Big RAND study that ended up being the kind of one of the primary justifications for the expansion of the IT spending in the stimulus bill in 2008. And whether it's right or not, that public funding argument developed in the decade before any real decisions were made, but it wasn't quite detailed enough. It didn't quite get to the right level of understanding. So I think where we are now is there's an incredible skyrocketing of the amount of data that's available, and any organization out there that's providing care, it's unbelievable how much stuff is available. Whether you can get it, whether you can do anything with it, whether you can generate insight from it is a totally different question. So we're kind of on this very, very steep opportunity part of the curve where if we can figure out how to use that data, we are going to be able to make really big change. And it's all, kind of fortunately or unfortunately, in this kind of the information technology to drive population health, there is a new set of questions that the EHR fabric that we've built is just not really very well set up to address. I can give one simple example here. In a population health-based world, there is a tremendous change in how people think about the physician network. Who's in it, who's not, how do you manage costs within the network, what happens when people leave. This is very, very different than what has happened before. But what you find is that there is it's not all within one institution. So EMRs are fundamentally built on a concept of all healthcare is provided within an institution. But with clinical integration and the legal requirements that people have in terms of trying to manage care on a going forward basis, the population health aspect of what's happening is largely not within the bounds of one set of organizations anymore. So the EMR fabric that we've built is actually a little bit inappropriate for this next set of challenges that we're facing. And so new ways of going about the problems is really what I think is the interesting part of the next phase of the evolution of the healthcare industry. And also please notice that because this is an event sponsored by a business school, I did put a return on investment calculation. It's not very precise, but the return is red and the investment is green. We have spent a lot of money on this. I think you told me I had to have something that was business school related in this presentation. So why? I mean, I think this is a kind of why is it that we're not able to drive the value in addition to the fact that the fundamental problem set has changed from the assumptions that this EHR fabric was built upon. And I think, this is an example I came across the other day of a member an organization that we work with. It's a very large organization. They've been implemented on leading EHR for a decade. They're a development partner of one of the leading EHR companies. And as we're working with them to try to figure out how do they get value out of this, they have 3,000 reports that they can pull down in a library through their EMR that are in the library. 300 of those reports are usable in any way, shape, in the least, kind of at all. Not very much, but they are usable. And it turns out that there are 10 fundamental analyses and reports that are being generated that are driving the future of, kind of the decisions within this organization. And every one of them is generated by an analyst on an Access database. And there's kind of a line outside this poor analyst door every morning to try to get the report. And you see this consistently in the healthcare industry today is that there are these healthcare IT analysts that are just at the very center of what it means to be able to generate useful information out of this vast and expensive electronic infrastructure that we've created. Turns out that it's harder than it looks to generate actionable insight. And I wanted to turn to why I think it's what it is about that actionable insight that's important. And I want to make sure I leave enough time for questions here. So I'm going to skip a piece here, which is why I think the EHR infrastructure is not really designed to do what we need to do now. but I do want to just mention a couple things on this. Is that the cost of breaking part of what we're trying to accomplish, I think, as a society, is we're trying to allow data to be much, much, much cheaper to be able to access in a productive and practical way. And by reducing the burden of accessing and getting your hands on data and being able to then make it comparable in some way, you actually create the opportunity for innovation to occur in terms of new data being tied together in new ways, in terms of people being able to create their own unique way to think about a user interface, for example. And right now, that's not happening because the cost of entry into this industry from an IT startup perspective, of which I had the privilege of leading one for a while, is utterly incredible in terms of how hard it is to break into this world that we have created. And in some ways, we've grandfathered a set of organizations to be local monopoly providers in terms of the IT infrastructure for healthcare organizations. And so I think one of the questions that I've got that I would love it if the policy and the research community would address is, what would it take to practically reduce the cost of interconnection of data so that you can do something with it by an order of magnitude, by 2 orders of magnitude? If we did that, the entire nature of what's happening in the healthcare ecosystem around technology would be dramatically different. The nascent efforts around the FHIR initiative are fantastic. It's the first real breakthrough that we've seen in terms of trying to really solve this interconnectivity problem, the cost of interconnectivity. But is it enough? Does it consider all the relevant use cases? And what are the other impediments to actually connecting systems in healthcare such that, from a practical perspective, from the perspective of an innovator or an entrepreneur, you can actually have a great idea, do great analysis, and have an option to actually create a business that would support this. Who's doing this research? And if I could ask, if I had any hope for my my time here today, is that a couple of research questions may kind of trigger for people, and we can get a more thorough and interesting look at them than we've had historically. But obviously, reducing the cost of interconnectivity is necessary but not sufficient to enable this massive change that we're trying to see in healthcare. And here, one of the things that's been fascinating to me over the years, and I don't know to what extent folks have looked at this or thought about it, but I kind of call it the problem of the pilot. So you can go back 30 years in the literature to what was being put out at the Regenstrief Institute, or what was being done as looking at what was happening within the Veterans Administration. And you can find great research in terms of what it takes to actually change practice, reduce variation in care, drive better cost and quality outcomes. And the pace at which these types of articles and findings are being published has only increased from there. And yet, we can't scale anything such that it has system-wide impact. It's too hard, it's too slow, and it's just not happening. That's the core problem that we're trying to solve. So, as I'm not being critical, except of us, because it's really hard and we haven't been able to figure it out yet. Why is that? Like, really, why have we seen so few examples of very interesting innovation move beyond the pilot phase or the one institution phase and move into some form of a rollout across this industry? I don't understand it. We have thousands of case studies that we generate as our organization. We incent our teams that work with our members to find the ROI on our systems. We have thousands, and yet I'll bet if I looked at the 1,000, I'll bet 900 of them haven't been replicated very far. It's enormously difficult. I think part of why this is true is the following, which I'm guessing you can't see, but I thought I would just read a little bit of. And this is kind of, it's really hard to actually get to something that's actionable. So here we've got a typical scenario. On the left-hand side, an administrator saying, hey, are we using all of our OR capacity? It goes to the analyst, and the analyst sends back a report and says, here's the number of reports we do by month. And then the administrator says, yeah, but is this volume good? Can we add a denominator to reflect capacity? I mean, isn't that important? and the analyst sends back, here's the average utilization using national benchmarks of what things should take. And then, but the administrator then says, hey, what about, shouldn't we adjust for kind of service line mix? And the analyst says, okay, fine, I can do that too. I can, I can adjust for the service line mix, and here's, OR 3 and 4 look like they're not being utilized very well. And then the administrator is saying, but who's got the block time? Who's got time blocked in OR 3 and 4? Why is that a problem? And you can see this just going back and forth and back and forth, and this iterative nature of generating insight in healthcare today means that things happen very, very slowly, and the level of investment for each organization to generate enough insight to really change their behavior is massive, because this process just keeps going on and on. As soon as you get the doctors involved, there's a different set of questions. Yeah, but you don't understand the staff in this OR is better than the other staff. They get things ready faster, so I don't have any control over exactly how fast I do things. You just see this constant devolution into further and further details. And as we're trying to understand this in terms of what does it take to move beyond this, we're trying to be very thoughtful about how do you think about creating scaled change. And again, this is a core problem in our industry right now. And so we actually think, there's a systematic approach that's expensive to do, but when you do it, it's actually yields a very good insights. What's the meaningful outcome we're trying to create? What is going to matter here? What's the minimum data set that would be necessary to inflect performance? How's that data, when it's analyzed, how is it going to drive different action? And who's going to take the action? And how do we get them the data and the insight at the right time so that they can actually take that action that will create this outcome? And what are the other supporting cast of characters that have to come together in the healthcare system in order to actually create that change that we're trying to create as well? And then, how will we know if we've gotten there? What is the desired outcome? And then how will we measure it at the end? How will we know if we've actually driven change as part of this process? And I think, to me, this is it's making systematic the process of driving data driving insight not based on technology and what data is available, but based on the problem set that's trying to be solved. And I'll show you how we're thinking about it here just very briefly, because we're trying to make this much more kind of systematic for ourselves. And people probably can't see this. I apologize for the size of the type. But the first thing is try to figure out what's working. What is the insight that's out there of organizations that are doing something that makes something happen? So what are the thorniest challenges? How do you think about top performers? How do you think about what they do differently? How do you think about kind of the flaws in how other people do things? How do you apply the insights? What kind of a solution could actually enable somebody to make change? And then make sure that's kind of the leftmost column. The middle column is then going through a little bit what I said before is what kind of data do you need inside the health system, coming from outside the health system? How do you enrich the data in such a way that it's useful for somebody who's got to make high volume decisions on an ongoing basis? And then how do you then get it to somebody? How do you get it to somebody in a workflow? And I think our industry has thought about analytic applications as not really workflow. It's obviously when somebody's ordering, when a physician is ordering something, there is a workflow associated with that. It has to go to the pharmacy, it has to be validated, et cetera. But the problem, what we have to do in this new generation of healthcare is to think about the analytics in terms of workflow. Who's going to take it? Who's going to do something with it? How will we measure the outcome? And what is the next step in the process in order to improve that virtuous cycle? So again, if anybody has any ideas on how to do this better, I couldn't be any more open to the suggestions. I do hope everybody in here feels like you're working on a worthy problem. It is massive how dysfunctional the system is out there. And this is not just words, it is a dysfunctional system. But we're on the verge of actually being able, now that we do have the data available, with the creativity necessary and the ability to generate innovation, we're on the verge of actually being able to do something about it, I totally believe. And by the way, if you are interested in some of these problems and you're having trouble getting research funding, we do have spots open in our new product development team. But more importantly, there is a opportunity, I think, for collaboration. We generate a massive amount of data that is at a very, very detailed level that comes from the provider universe. We're running through we have detailed information on 40% of the admissions that happen in the United States at the most detailed level that the organization captures that information. And so there's a tremendous opportunity. We've de-identified about half of it, but there's a tremendous opportunity. And I don't know exactly how we could do it, but I would be open for conversation because my team, my organization is not spending enough research time on what do you learn if you look at the data. And there is an amount of insight in there that I'm totally convinced of. So, back to my insights on doing my PhD, a worthy problem, a great question, and then available data that hasn't really been scrubbed by 1,000 other PhD students before you, I think is where we are from an opportunity perspective. So thank you all very much. I have kind of collapsed a lifetime into 30 minutes here, and really we'll look forward to Q&A from anyone that wants to lob questions at me. So thank you again very much.
Thank you very much. So if you'd like to ask a question, please step to the mic, and please also mention your name and affiliation when you ask your question.
Hi, name is Don Gilco. I'm from University of Cincinnati. Thank you very much for your talk and sharing with us your lifetime experience. I do have one quick question. I've been working closely with Cincinnati Children's Hospital.
Yep.
And what I have learned in terms of one of your comments you made with respect to the cost-effective means to drive this interconnectivity.
Yep.
A lot of the physicians and administrators, they see the value of IT because it's all implemented. I think one of the challenges because of the administrative roadblocks or processes or politics perhaps that might be preventing from this interconnectivity to occur. So just wanted to get your insight with respect to your experience or any suggestions you might have with respect to how that might actually be accomplished, because I don't think it's the technology itself, because they see the value of that.